fat intake in the occurrence of sudden cardiac death. Case and control. Okay, 150 cases and controls are matched by age, sex, and birth. Sex assigned at birth, race, and history of hypertension, hypercholesterolemia, and cigarette smoking. Dietary history, intake history of the cases is obtained from the next of kin. Results show an odds ratio of 1.6 with 95 confidence interval of 1.2 to 1.9. The authors conclude that there is a relationship between dietary fat intake and sudden cardiac death. Which of the following raises the most concern about the author's conclusion?
So is it calculation or is it just normal bias
I think it's normal bias thing.
thing? Okay. Differential bias occurs when there is an unequal classification of exposure to a risk factor between groups with or without the outcome under study. In this scenario, the family members of patient who died the family members of the patient who died of sudden cardiac death are more likely to recall dietary exposure to fatty food in comparison to a family member of patient who next of kin has not died of sudden cardiac death. Differential bias differs from non-differential bias, in which case in which case there is an equal risk for exposure misclassification between groups with or without the outcome under study. Differential bias may lead to skewing of the odds ratio. Differential bias may lead to skewing of the odds ratio toward or away from the null, and depending on the experimental design. In this scenario, a higher rate of misclassification of exposure to fatty foods in the group that experienced sudden cardiac death may lead to an erroneously high or skewing the results of the study. Okay,
Okay.
I don't got get it anything. Can you explain?
Oh, oh, they're saying that the bias come because the people that they're asking the family members for the patient diet. So let's say the patient died of cardiac death, and you go and ask the family members. They're saying that the family member are probably going to remember everything that the patient. They're going to tell you, yeah, he ate really bad. He ate a lot of fatty food. That's why he died and all that. Whereas if you ask just like the family members of a patient that's still alive, they're probably going to be like, I don't remember. He eats, yeah, he eats good, sometimes sweet, but they're not going to remember that well.
Okay,
That's what they're saying. But if your family member died, then you're gonna remember. You're gonna be
yes,
like, yeah, yeah. That's what they're kind of saying. That yeah, that's what they're saying here.
okay, okay, I'm coming within 1 to 2 minutes.
When woman comes to the physician because of a 2 month history of hoarseness, she has not had any other symptoms. She has no history of serious illness. Doesn't take medication. Smoke for 45 years. Examinations, including the oropharynx, is fine. Which of the following is the most appropriate next step in management?
Okay, I am asking a question like,
Mm-hmm.
suppose a woman wants to be pregnant and she is on lithium. What do you do now?
Woman wants to be pregnant. She is on lithium.
She is on lithium. She has previous history of like she has bipolar disorder. So
Mm-hmm. Mm-hmm.
she has previously there are 2 to 3 times of hospitalization
Mm-hmm,
due to
mm-hmm.
her bipolar disorder. Now she's stable with this lithium. Now she wants to be pregnant as early as possible. She came to you. What you will do?
What are the options? Because the only question I seen like that, it was
Yeah.
like the woman was already pregnant and
Yes.
she was already on her second semester, and now they're telling you should she stop lithium, and then the answer was no, because after the first trimester, then there is not that much chance of the Epstein thingy. So
Yes.
she continues the lithium, but that was she was already pregnant. So I don't know if
If
she's.
she is not pregnant,
I
if
don't. I
she is
don't.
not pregnant and she is on, if she is not, even if she is not pregnant and she
Mm-hmm.
is stable on lithium, do not
Mm-hmm.
stop the drug.
Do not
Carry
stop.
on with the lithium. That is the
Okay.
clue.
Okay, so even if she's pregnant or she's not pregnant, you continue. Do
Yes.
you add something to the?
No,
No. Okay.
because
Okay.
a single drug is enough to control the bipolar disorder. Like other options like valproic acid and carbamazepine,
Yeah.
uh, this should not be used. It can cause fetal neural tube defect. And
So,
the sorry,
so do you add like extra folic acid to the woman or something? Is that did they say
mm,
anything?
not really. If
Okay.
we use folic acid is used if somebody is on phenytoin. Phenytoin actually cause
Mm-hmm.
folate deficiency, but
Okay.
lithium does not cause.
Okay.
The only thing we need for lithium, we can see the lithium level and we can see the creatinine.
Okay.
Okay, okay. These type of questions are like very confusing in the exam.
Yeah. Yeah. I mean, I probably would have gone with keep the lithium still because I saw that question, but I didn't know. I never asked
Yes,
what if she's not
yes,
pregnant.
yes.
Yeah.
Like continue with the lithium would be the safe choice, but uh, if we see the option, we may get frustrated.
Yeah.
Okay. Okay. Laryngeal carcinoma. Laryngeal carcinoma may present with hoarseness, voice changes, persistent cough, stridor, or dysphagia is more common in patients with a history of smoking. The vast majority of the laryngeal carcinoma uh, are squamous, and location in the glottic or supraglottic region is frequent. Supraglottic lesions are likely to induce dysphagia, whereas hoarseness in early symptom of glottic lesion as a result of involvement of the vocal cords. The diagnosis is established by direct tumor visualization, which may be accomplished by direct laryngoscopy. Through examination of the neck is also essential to determine through examination of the neck is also essential to determine the extent of the tumor and to identify associated lymphadenopathy, which may indicate nodal metastasis. Distance metastasis can Distance metastasis may also occur. May be useful for character. CT scan or PET scan may be useful for characterizing metastatic disease. Early stage of laryngeal carcinoma is associated with high survival rate, although locally extensive or metastatic disease is more difficult to treat. Treatment involves surgical excision, radiation therapy, and chemotherapy. So in laryngeal carcinoma, we do the indirect laryngoscopy.
Yeah, it seems like yeah.
Okay.
Yeah.
Indirect laryngoscopy,
Hmm.
is it like endoscopy guided, this one, or direct? What
Let
does the
me see.
endoscopy?
Direct versus indirect laryngoscopy. Direct involves viewing the larynx with a straight line instrument, often used for procedures like intubation. So you
Yeah,
put a
both.
tube and you actually look into it.
Okay, got
And
it.
indirect laryngoscopy, on the other hand, visualizes indirectly using a mirror or flexible endoscope, typically in a sitting position. So indirect will be, I guess, something like this, where you put like a why is shown like this? Oh, where you put like
This may be endoscopy guided. Kinder Bueno. Okay.
no,
You like Kinder Joy?
no, it's just an app. It's not me. It's not me. It's just
Okay,
I
you
saw
are
the
seeing
picture and I
strep
thought,
place with like throat lozenges. Okay, good. You
yeah,
need you
it's
did
this
this.
picture that I was looking for. So you So it's like they put you see it's kind of like a thing with a mirror and you put it in the mouth and
Okay.
or something like a flexible tube and you put it. But direct, I'm guessing is like
Direct is like during intubation, like
yeah, during incubation kind of thing.
yes, that is the
Yeah.
thing.
Like they hear this picture. It seems like this one,
Okay.
like intubating, yeah. So it's kind of the same thing. It's just that one is with like during intubation and the other one is like you are awake and sitting and you know.
Yes.
Okay. 57 man is admitted to the hospital because of fever, shortness of breath, cough, or productive yellow sputum. He has prostate cancer metastatic to the bone. His only symptoms from the cancer is occasional back pain control with acetaminophen in hydrocodone. At his last appointment 6 months ago, his PSA was stable and his disease had not progressed 6 months ago. He plays golf several times each week and enjoys traveling with his wife. His advance director stated that he does not want intubation or mechanical ventilation unless he has an acute illness with a reasonable chance of recovering to a good quality of life. He is lethargic and unable to communicate. His temperature is high, pulse is high, respiration high, BP high. Pulmonary exam shows shallow, rapid breathing. He's using accessory muscles or respiration. Inspiratory crackers are heard in the right upper and lower fields, so kind of like pneumonia. pH is normal. Let me double check. Yeah, normal. PCO2 is normal and PO2 is low. X-ray of the chest shows diffuse right side the infiltrate. Which of the following is the most appropriate next step in my diagnosis?
So his advance directive that does not want to intubate.
Mhm.
Okay. Regardless of advance directive or prior code status documentation, patients need to assess all patients' code status during each hospitalization. As the context of each hospitalization differs, the patient or the if the patient decision maker, legal guardian or durable power of attorney should be given the opportunity to update the patient's code status during each hospitalization. This patient is unable to communicate and his acute hypoxia necessitates urgent decision by the physician as it responds an emergent and immediate life threat that is potentially reversible. Based on his advanced directive and current clinical condition, intubation and mechanical ventilation is appropriate reasonable chance of recovery with appropriate treatment. I don't get it.
Oh, he's saying that he doesn't want mechanical ventilation or intubation
The
unless
the advanced directive.
yeah, his advance directive of the patient. He
Okay,
doesn't want it
yes.
unless he has a disease that can be cured, unless he has something that can be treated, basically. So here, based on the symptoms, it seems like he has pneumonia, right? I think.
Yes,
Yeah. So pneumonia usually you can treat it with antibiotics. So
yes.
his advanced directive doesn't apply here because it's something you can treat. So then the doctor can yes, is able to use intubation and mechanical ventilation. Then
So even if it needs, he can surpass the previous order. Like if
no, he's
treat,
not.
like if somebody is told you to do not resuscitate DNR, then we do not resuscitate. Like we do
Uh-huh.
not intubate the patient, isn't it?
Uh-huh.
So is it fit? Is this condition fits for this area?
But here he's saying do not resuscitate unless. So you are just he's not
Yeah.
saying just do not resuscitate. He's saying do not resuscitate unless I have something that can be treated.
Okay.
Yes. So pneumonia can be
Can be
treated.
treated.
So yes, we can resuscitate. The advanced directive says unless. It didn't just say do not resuscitate. It said do not resuscitate unless I have something that can be treated. So it's the whole thing. So here, yes, he can be treated. So we're gonna do the resuscitate. Does it make sense or no?
Yes,
It does.
it
Okay.
makes sense, but I have plenty of question in here. Like he has prostate cancer.
Mhm,
The
mhm.
like he has prostate cancer, uh, and he has given the permission of DNR. Then why we are resuscitating? That's my question. Is it like if any treatable condition we will treat? Is that the
Yes.
rule?
So because of his DNR, we will treat because his DNR didn't just say DNR. It says DNR unless
Unless it is a
um
treatable and had
unless
a
it's yes. So it didn't just say do not resuscitate. It said more. So that's why we are doing it. We're doing it. If it just said DNR, then no, we wouldn't do that. We wouldn't do mechanical ventilation. Yeah, we wouldn't do it. But it's because he added it unless this. And I get what you're saying because you're saying, but he has prostate cancer, he's going to die in eventually, eventually. But it's just that what he put on his advanced directive, he specified. I want the mechanical intubate. I want it if I can, if I can be treated. If it whatever I have right now in this moment can be treated, not because of my prostate cancer that I had for years, but whatever I have right now that I'm coming to the hospital. If it's pneumonia, if it's an infection, whatever that if it can be treated, yes, I want the mechanical. That's kind of what they want you
okay.
to assume. Okay. Can you read B and C that one? This answer choice.
Beginning of non-invasive positive pressure ventilation by the face mask and continuing oxygen by face mask and administering IV morphine for comfort are both inappropriate and represent a misinterpretation of the patient's advanced directive. This patient has this patient with a lower pneumonia has this patient with a lower pneumonia has a chance of recovery with treatment has a chance of recovery with treatment and should be immediately intubated. Non-invasive positive pressure ventilation are reasonable. Non-invasive positive pressure ventilation is reasonable option for patients who are not at risk for airway compromise. However, that that is not the case. However, that is not the case with the patient and his mental status, hypoxic respiratory failure, increased work of breathing together indicate that invasive mechanical ventilation is most appropriate. Okay.
Okay. Next. 77 men comes to the physician because 3-day history of passing air and fecal materia during urination. He has a long-standing history of intermittent constipation. His last exam was 20 years ago, he smokes for 55 years. BMI is normal. 6 foot tall. Vital signs are normal. Abdominal exam shows mild distension. Bowel sounds are decreased. Rectal exam shows a diffusely enlarged prostate. There is no stool in the rectal vault. Lab studies, hemoglobin, I think it's fine. Leukocyte fine. Platelet, believe is high, I'm not sure. Urine, white blood cells a lot. And the urine and flora is mixed. Which of the following is the most likely cause of the patient's symptom? Hmm.
Also, the Christian Nash posted this the layer the layer of gastrointestinal wall the layer of uh, gastrointestinal wall from the lumen from the luminal surface to the exterior of the bowel will include the mucosa, submucosa, muscularis mucosa, and serosa. Diverticulosis, also known as diverticular disease, is characterized by a sac-like protrusion of the colonic wall that are hypothesized to develop secondary to increased intraluminal pressure. This predisposes the herniation of the mucosa and submucosa through the muscularis propria of the colonic wall. Risk factors for the development of the diverticulosis include risk factor for development of the diverticulosis include abnormal colonic motility, constipation, high dietary intake, high dietary intake of red meat, and low dietary fiber, physical, physical inactivity, and obesity. Complications of the diverticular disease include lower gastrointestinal bleeding and diverticulitis. Rarely, diverticular disease can lead to development of colovesical fistula. Diverticular disease comes with colovesical fistula in which there is connection the rectum and the urinary bladder. So colon, and vesicle, urinary bladder, colovesical fistula. This can lead to pneumochuria, here in the urine, pneumochuria, and passage of fecal material during urination, as well as the development of the urinary tract infection, as seen in these patient and seen in this patient with mixed flora and numerous leukocytes on urine analysis. Diagnosis involve contrast CT or direct visualization. Treatment involves antibiotics and surgical repair. Okay, so how you have diagnosed this diverticulosis?
Wow,
Usually,
that is.
diverticulosis has left lower abdominal pain,
Mhm.
but this patient does not like this. So, what is the clue here?
I didn't get it. I mean, I think here you just have to delete the other ones. Um, and then yeah, you'll get to the answer because there is not really a clue. Like it's not a typical question for diverticulitis, like you said, the lower abdominal thing. But if you delete the other ones, like it's not appendiceal abscess. There is no fever or anything. It says vital signs are normal.
Okay,
And it's not prostate cancer because the prostate is just enlarged, but he doesn't have any urine issues. Like he doesn't say he has any issues with peeing. And then it's not transitional bladder cancer because there is no blood in the urine. And then it's then you left with diverticular disease and inflammatory disease. And it's not inflammatory because the typical inflammatory is the
as
blood, the
bloody diarrhea
pump,
or watery diarrhea.
yeah, the abdominal pain and all that stuff. And he doesn't have any blood. So I think the only thing would be left would be diverticular. And it doesn't really fit the diverticular thing, but and I didn't know that diverticular could cause the the fistula, that fistula. That was my other thing. I didn't know.
Yes, colovesical fistula can happen.
Yeah.
But
Because I
in
know,
this stem there is something written about fistula.
um,
No, not
no, but
here.
the I mean, but the passing of fecal material through urination,
Ye-
it
Yes,
must be a fistula. Yeah, it must be a fistula that's forming there. I know Crohn's usually can cause the fistula. That's why I went with inflammatory bowel disease. I didn't know that diverticulosis could cause it too. But yeah, it's a fistula because there is no way like how does the poop can come from the urine? That
even
just means
even the risk factor does not fit with this. Like diverticular
yeah,
disease has
yeah.
obesity,
Well,
smoke.
kind of a little bit
Sorry,
fits. He has constipation.
sorry,
The risk
constipation.
factor, yeah, the risk factor kind of yeah fits a little bit. Yeah, he has constipation for 20 years. So yeah, I guess yeah, it fits a little bit. Yeah.
Okay,
Because you see, it says risk factors of diverticulosis, abnormal colonic motility, constipation, and diet, and obesity, and all that. He definitely doesn't have the obesity, but he has the constipation.
okay.
So,
So
yeah.
constipation, straining, this is associated with diverticulitis.
Mm-hmm. Yeah.
Okay,
Twen- yeah. 25 men comes to the physician 2 hours after the sudden onset of sharp right buttock pain that radiates to the back of his knees. Right buttock pain. The pain worsens when he sits for a prolonged period or drives. He's able to walk. Use of over-the-counter ibuprofen has provided mild relief. He has no history of serious illness, doesn't take medication. On exam, ipsilateral and contralateral straight leg test is positive. Muscle strength is normal throughout. Sensation is intact. Which of the following is the most appropriate next step in diagnosis?
okay. Lumbar disc herniation and piriformis syndrome are both common cause of sciatica. Disc herniation occurs most common following chronic degeneration combined with a minor traumatic event such as bending and lifting a heavy object, such as bending and lifting a heavy object causing an increase in the intradiscal pressure. Disc herniation typically presents with acute back pain along with symptoms of the lumbosacral or symptoms of the lumbosacral radiculopathy, including acute inflammatory pain and or weakness. Under or weakness, there is dermatomal or myotomic distribution with respect. Okay, I'm coming. 1 minute.
Mm-hmm.
Okay. Lumbar disc herniation and piriformis syndrome. Lumbar disc herniation and piriformis syndrome are both common cause of sciatica. Disc herniation occurs most often following disc herniation occurs most often following chronic disc degeneration combined with minor or traumatic events and lifting bending and lifting a heavy object causing an acute increase in the intradiscal pressure. Disc herniation typically presents with acute back pain with symptoms of lumbosacral radiculopathy, including acute extremity pain and or weakness in a dermatomal or myotomic distribution with repeat to the impinged spinal nerve. Piriformis syndrome presents similarly, but with pain reproduced with palpation of the piriformis of the affected site. Regardless of the cause, sciatica is diagnosed clinically through a combination of the history and the examination maneuver, including SLR, in which flexion of the hip while the leg is held on extension at the knee produce pain and in the lower back that usually shoots from down the leg. Lumbar imaging with MRI or CT scan is useful for patients with severe motor or sensory dysfunction but is not required for most patients with mild or moderate symptoms without an objective neurologic deficit in whom there is no concern for clinical there is no concern for spinal cord impingement. Trial of therapy generally appropriate before imaging such cases. Patients with evidence of muscular weakness may benefit from nerve conduction studies. Electromyography patients most patients with sciatica demonstrate spontaneous improvement with conservative management, including analgesia, physical therapy, activity as tolerated. Prolonged bed rest is not necessary for most patients and may cause worsen and prolonged recovery.
Okay, next. 16 girl brought to the physician by her mom because of a 8-month history of irregular menstrual periods, acne, and facial hair. Menarche was at 12. Menses occur at irregular 35 to 42 day interval. They last 1 week and flow is heavy. Moderate cramps on the first 2 days are relieved for ibuprofen. The patient had recurrent UTIs until age 10 years. She has no other history of serious illness, doesn't take medication. BMI is fine. She's 5'4". Temperature is fine, pulse is fine, respiration is fine, BP fine. Exam shows scatter, papules, pustule, and comedoma over the face. There is sparse, coarse hair over the chin. The neck is supple. There is no thyromegaly. Breast exam shows no masses. Breast and pubic hair developmental in stage 5. I guess that's normal. Serum studies most likely to show an increased concentration of what? Mm,
Okay, it's polycystic ovarian syndrome, and in PCOS, LH-FSH ratio is more than 2:1 normally.
okay.
So, and in polycystic ovarian syndrome, like there is a mnemonic called leptin, LH, estrogen, prolactin is increased.
Okay, just let me write it down. Is the mnemonics for the symptoms or?
Mnemonics for the investigations
Mhm.
like LH, estrogen, prolactin, or testosterone is increased. Like a word, the leptin, LAPTIN.
That's
So
LA. Uh-huh.
LH, E for
Uh-huh.
estrogen, P for prolactin, T for testosterone, and IN means increase.
Testosterone are all increased. Okay. LH estrogen. Okay. All right. Okay.
So polycystic ovarian syndrome presents with irregular men's menorrhagia, infertility, acne, hirsutism, often in patients with increased body weight. It requires two of the following diagnoses. It requires two of the following for diagnosis: oligo or anovulation, polycystic ovaries on ultrasound, and clinical or biochemical signs of hyperandrogenism. It is associated with signs of insulin increase. It is associated with signs of insulin resistance such as acanthosis nigricans and increased blood glucose concentration, and PCOS is caused by the abnormal hypothalamic hormonal feedback response, which leads to increased LH hormone in comparison to FSH hormone, as well as markedly increased androgen testosterone production from the theca lutein cell. so markedly increasing the androgen like testosterone from the thicker lutein cells. And treatment is weight loss, combined OCP, and menstrual regulation, and spironolactone ketoconazole for hirsutism.
Can you read A, B?
Yes, follicle stimulating hormone may be increased in menopause or in central precocious puberty. It, its role in the hypothalamic pituitary gonadal axis is to stimulate the production in the ovary to support an egg for development. It is not increased in the same degree as the LH in the PCOS. Both 11 hydroxyprogesterone and 21 are precursor of aldosterone and thus carry a degree of mineralocorticoid activity. Increased mineralocorticoid be expected to produce hypertension, hypokalemia, metabolic alkalosis, metabolic alkalosis, depending on hormonal activity of the precursor. It would not explain this patient's ovulatory dysfunction and hyperandrogenism.
Okay. Next. 49 woman comes to physician for preoperative examination before she undergoes cholecystectomy. During the past 3 years, she has had recurrent cholecystitis and multiple gastrin. She has not had shortness of breath or difficulty swallowing or hotness. She has rheumatoid arthritis with morning stiffness and widespread joint swelling. Her medications are methotrexate, folic acid, prednisone. Vital signs are normal. Exam shows nodules over the extensor aspect of the upper extremity. There is swelling of the wrist, metacarpal penis. There are swelling neck, so rheumatoid arthritis. The remainder of the exam is fine. Which of the following is the most appropriate next step in management to decrease this patient risk of for operative complications?
Okay, X-ray of the cervical spine.
Mm,
Rheumatoid arthritis is an autoimmune disorder characterized by systemic inflammation that prominently affects the synovial joint. It is a chronic, progressive, often leading to significant morbidity. Symptoms include gradual onset of symmetric arthalgia and joint swelling as well as morning stiffness, commonly in fingers and the wrists. Chronic disease can progress to affect proximal joints and the cervical spine and leads to significant joint damage and deformities. Severe disease can cause systemic disease. Severe disease can cause systemic disease such as interstitial lung disease, vasculitis, pleuritis, pericarditis, anemia, and subcutaneous nodule. Atlantoaxial involvement is common in chronic disease and may be associated with subluxation with consequent spinal cord injury or radiculopathy. Evaluation of the cervical spine with flexion and evaluation of the cervical spine with flexion and extension. X-ray in patients with chronic RA. X-ray in patients with chronic RA is appropriate prior to general anesthesia to evaluate for atlantoaxial instability and inform the technique for intubation. Direct laryngoscopy is often used to intubate patient for general anesthesia. Involves significant extension and flexion, which would lead to catastrophic neurologic damage in the setting of atlantoaxial instability. With significant instability, intubation with inline stabilization is needed. Therefore, most appropriate next step in the management in this case is X-ray of the cervical spine to evaluate risk for direct laryngoscopy.
Can you read B as in boy?
Discontinuation of the prednisolone is not necessary. It acts anti-inflammatory and immunosuppressive. It acts as an anti-inflammatory and immunosuppressive agent in the treatment of RA. Discontinuation of chronic prednisolone can cause adverse effect as long as prednisolone therapy can cause adrenal insufficiency if discontinued. Thus, chronic prednisolone therapy may necessitate stress dose steroid prior to patient's procedure, and discontinuation of prednisone may be harmful. Okay.
Okay. Next. 32 women, gravida one para one, comes to the physician because of spontaneous discharge from her nipples during the past 3 months. She discontinued breastfeeding her child 1 year ago. She takes no medications. Menses are regular. On physical exam, a milky white discharge can be expressed from both nipples. Exam shows no other abnormalities. Fasting serum prolactin is 40. I do not know if it's the missing prolactin. Did I miss it? Where is prolactin? Oh, we don't have prolactin here. I guess. Okay. Oh, it's right here. Female, less than 25. Okay, so prolactin is high. The most appropriate next step in diagnosis is measurement of which of the following.
So, what is your diagnosis?
I don't know. I thought it was maybe a prolactinoma, but I guess no.
No, it's not prolactinoma. So, an abnormal increase in serum prolactin is defined as hyperprolactinemia. Hyperprolactinemia causes non-physiologic discharge of milk from the nipple and a growth of the glandular breast tissue. A diagnosis of hyperprolactinemia A diagnosis of the hyperprolactinemia is made when the serum prolactin concentration is greater than 30 nanogram per ml, 30 nanogram per ml in premenopausal women of greater than 20 nanogram per ml in women and postmenopausal men. After cessation of the breastfeeding, serum prolactin level typically return to the pre-pregnancy level. Common cause of hyperprolactinemia include hyperfunctioning of the pituitary microadenoma, hyperfunctioning of the pituitary microadenoma, hypothyroidism, and dopamine blocking medication. As prolactin is negatively related by dopamine, prolactin is positively regulated by TSH or TSH releasing hormone instead of hypothyroidism with unregulated TRH. Galacturia can also occur. The initial workup would involve measurement of the TSH concentration and evaluation of any dopamine blocking medication the patient may be taking. If these steps are unremarkable and further diagnostic evaluation should include MRI of the brain to assess the presence of pituitary adenoma. Treatment of hypothyroidism, if present, will resolve the hyperprolactinemia and patient's symptoms. Can you explain this?
Oh, I mean, they're saying that if TRH has a positive, so if you have a low T3 and T4, then there will be like a positive feedback. Is it positive? Anyway, TSH and TRH will be increased, right? Because you have low T3, T4. And
Yes,
if, yeah, and if TRH is increased, it stimulates TSH, but it also stimulates prolactin release. So that's
yes.
what there's. Hmm. So if you have a, so that's why they're saying to first check TSH and TRH. If it's increased, then that's probably what's causing the prolactin increase. And you also check if the patient is taking any dopamine blockers, because dopamine normally suppresses prolactin. So if you take a dopamine blocker, then there will be a lot of prolactin. So they say to check those first.
Okay.
Does it make sense? Yeah.
Yes.
Now I didn't know why it wasn't like. Then the answer wasn't B, but so I read B, and it says that you have to check if the patient is taking dopamine blocking medications. You don't check the
Like
concentration.
anti-Parkinson drugs. No,
Yeah,
no,
you
no.
don't.
Anti-Parkinson drug is dopamine agonist.
Oh, it's dopamine agonist. Sorry, the anti the
Dopamine
what is it?
antagonist is metoclopramide.
Yeah, those ones. Uh-huh. And you don't check the serum dopamine. You check the dopamine blocker medication. You don't check the actual serum dopamine level because it's not an accurate measurement. That's what they're saying.
Okay.
Yeah. Okay. Next. 57 men comes to the physician for follow-up. 1 year ago, he sustained an MI. He has coronary artery disease, hypertension, type 2 diabetes, medication statin, lisinopril, metformin, metoprolol, aspirin. He has smoked for 25 years. He's 5'10". BMI is high. He feels well. His pulse is just fine. But BP is 145 over 78. That's fine. Exam shows no abnormality. Lab study shows hemoglobin 6.5, which I think is fine. LDL cholesterol concentration is 110, which is
Normal.
fine.
Yes.
Serum electrolyte, urea, glucose, creatinine, everything is fine. The physician recommends smoking cessation. Addition of which of the following is the most appropriate next step in pharmacotherapy? I guess the blood pressure was not fine. It was high.
B, BP 140 over 90, though it
Mm,
is not 90. Okay.
I guess glucose is fine. It's 6.5, but the normal is less than is 6. I guess it's fine.
Patient with high a patient with history of acute coronary syndrome increased risk for further adverse cardiovascular event. Management focus on modifiable risk factor to reduce the risk. And patients with counsel for smoking cessation, healthy diet, regular common comorbid conditions that comorbid condition that contribute to common comorbid condition that contribute to increased risk include hypertension, diabetes, metabolic syndrome, and hyperlipidemia. American Heart Association recommends blood pressure go less than 140 over 90 for adults, and when the patient also has diabetes or chronic renal disease, the goal can less 130 over 80. This patient,
Okay.
he has mm, this patient has blood pressure goal and addition second antihypertensive agent. Hydrochlorothiazide would be the most benefit in this time. There is one point I want to ask, like why not hydrochlorothiazide? Why hydrochlorothiazide? We know that one of the side effect of hydrochlorothiazide is hyperglycemia. This patient has diabetes. So why we are giving this drug? Why not another drug like
Which, which other one would you give?
mm, like why not? Usually spironolactone should not given alone. Spironolactone is a potassium sparing drug. Like if there is no calcium channel blocker, we can add calcium channel blocker. Like
There is some
no
channel block.
calcium channel blocker. That is one thing. So there is no other drug we can use because the like I don't want to add hydrochlorothiazide as because this hydrochlorothiazide causes hyperglycemia. As the patient is diabetic, why we are giving such a drug that causes hyperglycemia? That my query. Okay, I understand. For adding the second drug, like the pressure is higher than our target. Like our target is 130/80. That's why we are adding second antihypertensive. Okay.
Okay. Can you read B and D, BD?
Exenatide and sitagliptin is a second line anti-hyperglycemic agent like glucagon like peptide receptor agonist and dipeptidyl peptidase 4 inhibitor, dipeptidyl peptidase 4 inhibitor classes respectively. Both are reasonable choices to add for patients who are not meeting glycemic goal with metformin monotherapy and lifestyle changes. HbA1c 6.5% is an acceptable concentration for a patient with known cardiovascular disease. A tighter glycemic control has a high risk of adverse event and a high risk of adverse effect from hypoglycemia with no benefit. Okay.
Okay. Yeah. 60, women with osteoarthritis of the right knee comes to the physician to discuss treatment option, including total knee replacement medications and naproxen and aspirin. Vital signs normal. Exam shows edema of the right knee. Range of motion of the right knee is decreased. Results of lab studies are fine. The patient asked the physician about the success and complication rates with total knee replacement at the local university hospital. Which of the following type of study is most appropriate for the physician to reference to answer this question?
Okay. This is institutional case series. Uh, institutional case series. I don't know how it got right. A case series. A case series study is descriptive study that describes the history, possible exposure, clinical findings, treatment results of a group of patients with a similar diagnosis. Case series studies are non-analytic and they do not non-analytic and they do not imply a cause and the effect of a relationship. They do not test for hypothesis, not they randomized. They are useful in characterizing the natural history. They are useful in characterizing the natural history of the disease in response to the treatment which are in response to treatment and are also useful in evaluating the outcomes in a particular procedure and patient of a particular procedure of a patient or a patient population at a single institution. They are useful in describing rare disease as the small population size may not permit conduction a larger cohort or randomized control trial with sufficient power. Okay, can you explain?
Oh, um, no, they're just saying that because they're just
Because
saying
it is
that
a
there
rare thing.
is a rare thing. I guess we cannot use case control because you cannot take people. I don't know how you will select cases and controls from that and then look at the exposure. That's not the goal. She just wants to know. Yeah, I don't know how you will select that from one hospital. I guess that doesn't really make sense. But the case series, you follow the people that have gone through the surgery. You follow them, and you I guess you ask them, okay, how did the surgery go? And you see that okay, they don't have any complications from the surgery, and it's a small number of people because it's just one hospital, right? So you're not going to have like a million people that had the surgery. It's probably going to be like, I don't know, three or four or something that had at that specific hospital. So you just ask them, okay, how did it go? Whatever. Yeah. So it's for rare diseases, basically. Rare intervention, rare diseases, something where you don't have a lot of, uh, of people to interview. That's what they're saying, case series.
Okay.
Mhm. Can you read D as in dog, as in donkey? Sorry.
Randomized controlled trials are a type of prospective randomized controlled trial are a prospective interventional study design wherein patients are randomly assigned to receive a particular intervention. The intervention may be compared against placebo therapy or standard therapy depending on the study design and the disease being studied. When combined with blinding procedures, randomized control studies from a gold standard medical research and generate more powerful evidence than other forms of observational or descriptive study. Okay.
Okay, this one makes sense. Okay. Oof, what is this?
Is it stuck on appearance?
Second appearance, yes. And it's asking us which of the following is the most appropriate diagnostic study at this time.
So it is just visual thing. Stuck on appearance seborrheic keratitis, isn't it?
So, so you not study, you just let
No,
it
no,
continue.
no,
Oh,
no. I will read the explanation.
okay.
I think that in the like in the question there is nothing to figure it out. Is there anything? Okay, I'm reading the explanation. Then you match. Is there
Okay.
anything related to the question? Okay, seborrheic keratosis is a benign proliferation of the epidermis. It is characterized histologically by a benign acanthotic proliferation of the keratinocyte with the absence of cellular atypia. The lesions are typically round, raised, brown, or tan in color and sharply demarcated with adherent or stuck-on appearance. Seborrheic keratosis is common in the middle-aged or older patient. It is associated with increased age. Seborrheic keratosis is benign and the sudden appearance of the numerous seborrheic keratosis lesions on the back and the trunk known as a laser trillet sign and can be a paraneoplastic manifestation with GI malignancy. The diagnosis of seborrheic keratosis is established based on clinical appearance and no diagnostic study is needed. Treatment is not necessary, although lesions that are not cosmetically bothersome and may be removed with cryotherapy or simple excision. Okay,
Okay. Can you read B?
yes. Is there anything important found in this stem?
Let me see. Strange mole, 6 months. It has enlarged. It's mildly itchy but not painful, not bleeding, no weight changes or no cancer. So vital signs normal. Photograph. No, there's nothing else. So yeah, yeah, that's fine. It's like there is no signs of cancer, like gastric
It's
cancer.
just visual
Yeah,
observation.
yeah. And they're asking for the diagnosis, not for treatment. Okay, okay, okay.
So full thickness biopsy of the lesion, and shape biopsy of the lesion are the methods of obtaining tissues for histopathologic analysis during the diagnosis of benign or malignant cutaneous neoplasm. Shape biopsy may be adequate for initial diagnosis and certain malignancies such as basal cell carcinoma. Other techniques such as punch biopsy or excisional biopsy are more appropriate where when determination of the breast loss thickness biopsy of the seborrheic keratosis is not usually necessary.
Okay, got it.
Okay.
Yeah, next. 27 woman brought to the ED because 2-day history of fever, pain with urination, progressive generalized weakness. She has a SLE, complicated by nephritis. Current medication, prednisone and cyclophosphamide. Temperature is high, BP high, pulse high, respiration high, BP low. Exam shows warm, flushed skin. There is moderate suprapubic and right flank tenderness. Leukocyte count is high, a lot of neutrophils, and I guess bands. Everything else is normal. I don't know if monocytes is, I don't know. Urinalysis shows like a lot of white blood cells. Gram state shows numerous gram-negative rods. Um, IV administration of piperacillin and tazobactam, and 2 liters of saline is started. 30 minutes later, her pulse is, I guess, it's even more increased. Yeah, it's still high, and BP is still low. Which of the following is the most appropriate next step? She had an infection.
What is your diagnosis?
She had an infection, has a leash, fresh skin, blah blah blah.
The important thing in here, like neutrophil is high.
Neutrophil is high. Okay, so she had an infection. They gave him antibiotics and IV, but the BP is still low.
Yes, if after giving, like, after think about adrenal insufficiency in this way, like if somebody has hypotension, tachycardia, and you are giving fluid, even if you are giving fluid, the patient is not improving.
Mm-hmm.
Even you use the vasopressor, she may benefit in addition to the vasopressor. However, her history of chronic corticosteroid use for SLE should be in the consideration, as she has SLE, so she is on steroid previously, so she may have adrenocortical insufficiency. That's why it is not correcting. Our BP is not correcting, even if you are giving fluid or this and that. Okay. So this patient's hypotension, tachycardia, and this patient hypotension, tachycardia failed to improve. Hypotension, tachycardia failed to improve after initiation of the antibiotic and the fluid resuscitation. She may present She may benefit from addition of the vasopressor. However, her history of chronic corticosteroid use, her history of chronic corticosteroid use for SLE should prompt the physician to consider acute adrenal insufficiency and adrenal crisis precipitated by severe infection. Adrenal crisis is a life-threatening emergency. Adrenal crisis is a life-threatening emergency. Prompt administration of the hydrocortisone is the most appropriate next step in the management. In secondary adrenal insufficiency with a chronic in a secondary adrenal insufficiency as a chronic exogenous steroid use and the acute stressor suddenly increases physiologic demand for cortisol and the adrenal glands are unable to meet the demand. Adrenal glands are unable to meet the demand. This results in inadequate vascular tone to maintain blood pressure. Survival dramatically Cervical dramatically increase the early recognition and management of the adrenal crisis. Okay.
Okay, next. 72 men comes to the physician because 3-month history of progressive shortness of breath, non-productive cause and fatigue. During this period, he has had early satiety resulting in 5-pound weight loss. Okay. He has no non-sick contacts. He has 20-year history of COPD and 10-year history of hypertension, current medications, inhaled bronchodilator and oral thiazide diuretic. He has smoked for 50 years. He's in mild respiratory distress. He is BMI is 19. He's 5'5". Temperature is fine. Pulse is high. Respiration normal. BP 130 over 90. Pulse oximetry and oxygen saturation is 87. Exam shows no scleral icterus, jugular venous distension. There is jugular venous distension. Breath sounds are distant. There is right ventricular heave and loud S2. Grade 2 out of 6 systolic murmur is best heard over the left sternal border. The liver is tender, smooth, and pulsatile. There is no peripheral edema. Hematocrit is 50. Leukocyte count is fine. Platelet is fine. Which of the following is the most appropriate next step? Let me look at the hematocrit. It says 50. I don't know why I feel like this is high. No, it's
Like
normal.
their hypoxia causing high hematocrit. Hypoxia
No,
cause. Sorry.
hematocrit is fine. It's fine. It's not high. It's fine.
Okay.
Mhm.
Okay. So he has COPD, the most appropriate next step in the management in home oxygen therapy. This patient presents with right-sided heart failure secondary to COPD. Right-sided heart failure secondary to COPD. This is referred to as cor pulmonary, meaning pulmonary heart in Latin. Chronic lung disease is association with chronic lung disease is associated with pulmonary hypertension and similar to systemic hypertension. Pulmonary hypertension and similar to systemic hypertension, causing left-sided heart failure over time. The right side of the heart fails as a result of increased demands of pumping against the elevated pulmonary arterial resistance. Patients presents with signs of venous congestion which are seen in this patient with jugular venous distension and a pulsatile liver. Structural changes to the right ventricle are evident with a palpable have a physical examination and a loud S2 as the pulmonary valve slaps shut under the increased pulmonary pressure. Mortality in severe COPD is improved by smoking cessation, home oxygen therapy. Home oxygen therapy, and in addition to improving peripheral oxygenation, reduces supplemental oxygen sub supplemental oxygen where I am supplemental oxygen reduces the extent of the vasoconstriction that contributes to increased pulmonary vasculature, reducing strain of the right ventricle, reducing strain of the right ventricle. Okay, so this patient has cor pulmonary, right heart failure due to lung cause like COPD, evidenced by JVD extension, and there is
You hear me?
Yes,
Okay, sorry about that. Can you see my screen?
yes.
You were about to ask something.
Okay. Can you tell me the criteria of giving LTOT, like long-term oxygen therapy?
Oh, shoot. I don't know. There was something about, I think it's oxygen less than 88%, and I don't remember the other ones.
SaO2, like SaO2 is less than 88% and PaO2 is less than 55 millimeter of mercury at rest or during sleep. So SaO2 is less than 88 and PaO2 is less or equal
Then,
55 millimeter at rest or during sleep.
okay.
There is another criteria like SaO2 is less than 89% and PaO2 is less than 59% at rest and during sleep. At rest or during sleep in patients with evidence of pulmonary hypertension, that pulmonary hypertension like core pulmonary, like this patient, peripheral edema, right atrial or ventricular enlargement, or if there is polycythemia, if hematocrit count is more than 55. And then we give the long-term oxygen therapy, and we give the oxygen like low dose oxygen for more than 15 hours per day for better survival. For okay.
Okay. Next. 4 days after admission to the hospital for treatment of MI, a 72-year-old woman has the sudden onset of shortness of breath and confusion. She has AFib, diabetes, hypertension, cholesterolemia, medications that thiazide, ACE inhibitors, metformin, statin. She has smoked for 50 years and has drunk 1 glass of wine daily for 52 years. She's anxious and oriented to person but not to place and time. Temperature is fine. Pulse is high and irregular respiration high, BP low. Pulse oximetry is 100 on 100. Oxygen face max is like 91%. The skin is cool to touch. Exam shows jugular venous distension. Decreased breath sounds are heard at the lung bases. Bilateral scatter expiratory wheezes and crackle are heard. Rub is heard in the lower lobe of the left lung. 2 plus pretibial and pedal edema bilaterally. Hemoglobin is bit low. Leukocyte count normal. Segmented neutrophils is high. Benz is normal. Lymphocyte is normal. Monocytes is normal. Sodium is normal. Potassium normal. Bichloride normal. Bicarb is low. Glucose normal. Creatinine kinase. Okay. Lactic acid is high. Creatinine kinase. Let me see. What is it? I feel like I saw it somewhere here.
Creatinine kinase may be normal.
Creatinine. What is she? A female? Creatinine kinase is normal. Arterial blood gas pH
Is
is
low, very low.
PCO2 is low and everything is low.
Metabolic
ECG is
acidosis
um,
or
okay.
respiratory acidosis. No, no,
This
metabolic acidosis.
metabolic, yeah. ECG is shown. Check says ratios cardiomegaly and pulmonary infiltrates and pleural effusions bilateral. Which of the following is the most appropriate next step for diagnosis?
So she has hypotension, tachycardia, irregular pulse, hypotension, tachycardia, irregular pulse. What is your diagnosis?
Seems like he has. It looks like AFib, right?
Yes.
It's a irregular. Yeah, like AFib,
Okay.
and with heart failure kind of symptoms.
So cardiogenic shock may happen, and
Okay.
patient is in a shock and related to cardiac problems, so it is cardiogenic shock. So this patient is in the state of cardiogenic shock, tachycardia, borderline hypertension, cool extremity evidenced by pulmonary and venous congestion, pulmonary and venous congestion. On physical examination and in imaging, it is important to rapidly identify and treat the cause. Echocardiography provides diagnostic information quickly at the baseline. Acute and subacute complications. Acute and subacute complications of the myocardial infarction include papillary muscle rupture with subsequent mitral regurgitation, dysarrhythmia, cardiogenic shock, pulmonary edema, ventricular wall rupture, and post-infarction pericarditis. Echocardiography can identify most causes of cardiogenic shock at the bedside and guide for further treatment.
Are you with BD, B and
CT,
D?
CT angiography is the scenario of time consuming and is unlikely to provide actionable diagnostic information. Coronary CT angiography is useful in the outpatient setting and should non-invasive method of identifying obstructive coronary artery disease and patients at risk of our major adverse cardiovascular event.
I thought CT was for PE.
CT angiography.
Or no? Am I confusing?
No, CT angiography. CT pulmonary angiography is for P. Yes, you are right.
Okay, so it's also for coronary artery disease, I guess.
Yes,
Okay.
it can be like uh coronary artery disease. Okay.
Okay.
So
And
and
D.
D
Mm-hmm.
measurement of BNP, brain natriuretic peptide concentration will not provide useful information in the management of patients' acute shock. It is expected to increase in the setting of heart failure. Is increased in the setting of heart failure. This patient is displaying clear clinical signs of clear this patient is displaying clear clinical signs of cardiogenic shock with recent ischemic damage to the myocardium and urgent definitive diagnostic testing is needed. Okay.
Okay. Yeah. So there is coronary CT angiography, and I'm guessing the other one is pulmonary CT angiography. Pulmonary CT angiography. And the but for the pulmonary CT angiography, you do it in the emergency thing or emergency, or do you do it like in a
We do not
non-emergency?
do it in emergency setting. CT pulmonary angiography is not done in emergency setting.
Okay. Okay.
If you suspect PE
Uh-huh.
and patient is hemodynamically unstable, go for
Uh-huh.
treatment. You don't need to diagnose because after you diagnose, in the process of diagnosing, the patient will die.
And if he's stable?
If he is stable, then CTPA can be done. And if the patient has like kidney problem, as CT
Mhm.
pulmonary angiography gives some sort of dye, so then you can go for other thing like VQ scan. And if the patient is pregnant, you can go
Mhm.
for the VQ scan.
Okay, got it. Two
Okay,
month
can you tell
holder.
me like in COPD, like in previous question, there are two things. There are two options, like there are something which reduces mortality and there are something which reduces hospitalization for patient with frequent exacerbation. What are that things? Like like I am talking about, there was a question in the UR,
Mhm.
like smoking cessation, pulmonary rehabilitation,
Mhm.
smoking cessation, pulmonary rehabilitation,
Mhm.
vaccination,
Mhm.
and LTOT. These four things actually, uh, long-term oxygen therapy and nocturnal non-invasive ventilation if daytime hypercapnia. These
Mhm.
things actually reduces mortality, like smoking cessation, pulmonary rehabilitation,
Mhm.
vaccination, long-term oxygen therapy, and
Mhm.
nocturnal non-invasive ventilation if daytime hypercapnia.
Mhm.
These five things actually reduces mortality.
Mhm.
And if you do the lung volume reduction or lung
Mhm.
transplant in advanced case, uh, these things actually reduces mortality.
Mhm.
And long-term macrolide like azithromycin weekly
Mhm.
3 days, and if you give the roflumilast like phosphodiesterase 4 inhibitor and some
Mhm.
biologics like anti IL-5 monoclonal antibody, these three things actually reduce hospitalization: long-term macrolide, roflumilast, and biologic therapy. You got my point?
Mhm.
Okay.
Okay. Got it. Got it. Oh wait, where am I here? 2-month-old girl brought to the clinic by her mom for wet child. Mother says the daughter is exclusively breastfed. It takes 1 hour to complete the feeding, and her daughter sweats during feedings. The patient is at the 10th percentile for weight, 50%, and she was at the 50th percentile her last exam 6 weeks ago. All the growth parameters are remain stable at the 50th percentile. Vital signs normal. Lungs are clear. Cardiac exam, there is a 3 out of 6 systolic murmur heard best at the lower left sternum border. The deviated edge is palpated 5 centimeters below the right, so it's the heart is big. Which of the following is the most likely cause of this patient's failure to thrive?
Okay, what is your diagnosis?
I guess it's VSD. I don't know why I choose.
Just marble location. Apart from this, it is very hard
Mm-hmm.
to diagnose. Like VSD occurs in the left lower sternal border.
Yeah, that's what they say last
Yes,
lowest.
and it is holosystolic, like systolic murmur, MRT or VSD. This is holosystolic murmur. So this there are 2 points. Okay, VSD are among most common congenital heart malformation. They may occur in isolation or in association with complex structural abnormality. The genetic cause of VSD is heterogeneous and includes a known association with well-defined syndrome, known association with well-defined syndrome such as Down syndrome, DiGeorge syndrome, Holt-Oram. It may also occur in isolation and via non-specific random mutation and individual point mutation that are de novo. VSD are characterized by holosystolic murmur-based heart in the lower left sternal border, and may have an associated powerful thrill. VSDs result in left to right shunt, which increases pulmonary blood flow. They are acyanotic lesion. If uncorrected, the increased pulmonary blood flow may result in the pulmonary artery remodeling and consequent pulmonary arterial hypertension, which may cause a reveal of shunt from the right to left. This process is referred as Eisenmenger syndrome, clinically fatigue with feeding, sweating with feeding, fatigue with feeding, sweating with feeding, hepatomegaly, or the absence of murmur, only findings. Okay,
Can you read B and C?
yes. Congenital hypothyroidism is frequently asymptomatic at birth. Congenital hypothyroidism is frequently asymptomatic at birth, through they may present with lethargy, hypothermia, feeding problems, hoarse cry, myxomatous faces, macroglossia, hypotonia, umbilical hernia, prolonged jaundice, dry skin, along with intellectual disability in childhood. And Fabry disease is an X-linked autosomal. Fabry disease is an X-linked lysosomal storage disease that results from deficiency of alpha galactosidase A. Ocular manifestation include cataract, retinal vascular toxicity. Cardiac manifestation include left and right ventricular hypertrophy and conduction defect. This patient lacks other stigmata of the condition and is generally female, making presentation such rare.
Okay. Next. 67 men comes to the ED because of 12-hour history of increasing severe generalized cramping pain that began in the left groin and spread to his abdomen. The patient rates the pain 10 out of 10. He previously has noted the hernia in the left groin area. He says, normally I can push it back, but this time I couldn't. I was going to wait and make an appointment with the PCP, but I couldn't tolerate the pain. Has hypertension treated with verapamil and thiazide. The patient appears uncomfortable. Temperature is fine. Pulse is fine. Respiration fine. BP high. Cardiac exam discloses S4 gallop. Bowel sounds are increased. And the abdomen is soft with moderate diffuse tenderness. Tender mass is present in the left groin, extending into the scrotal sac. And the skin overlying the groin is red. Um, Lab results. Hematocrit, I believe, is fine. Hemoglobin, I believe, is fine. WBCs are high. Neutrophils high. Um, bands high. Lymphocyte low and monocyte low. pH, I believe, is normal. I never remember those things. pH is normal. PCO2 is normal, and the other one is normal. Physician contacts the on-call surgeon to see the patient. The surgeon instructs the physician to attempt reduction of the hernia and to call back if unsuccessful. Which of the following is the most appropriate next step in management?
Okay. So, inform the surgeon that the patient needs to be evaluated. An incarcerated or strangulated hernia. Incarcerated or strangulated hernia represents a surgical emergency. Strangulation presents with severe pain in the hernia site. Strangulation results in severe pain in the hernia site, often with underlying reactive erythema, fever, leukocytosis, and a tender fever, leukocytosis, and a tender, irreducible mass on examination. In extremis, sepsis, septic shock can raise from necrotic bowel. Immediate surgical exploration is necessary. On-call physician have an obligation to act ethically to promote the patient's best interest and to respond to call for the patient care in a timely fashion. Additionally, on-call physicians are requested under the EMTALA Emergency Medical Treatment Active Labor Act to appear to perform in-person evaluation, if summoned by another physician. Failure to perform in-person evaluation is the scenario deviates from standard care and may result in harm and represent negligence, which may be interpreted as medical practice. When encouraging a uh, colleague who is neglecting their duties while on call, the consulting physician should remind their uh, colleague of the obligation and escalate the demand for the patient to be seen or to locate another surgeon if necessary. Physician should follow appropriate guideline following MTELA. Okay,
Yeah.
can you explain?
Oh, oh, it's saying that the wait, what do you want me to explain? Like it's an emergency, so the surgeon should come. Like the surgeon should come to do the operate to do the surgery. If the surgeon, he called the surgeon here, the doctor at the hospital called the surgeon, come to do the surgery, and the surgeon said, try to reduce it yourself, and call me back if you're not able to reduce it. So at that point, since it's an emergency, the doctor has to tell the surgeon, no, I'm not going to do it. You need to come and do the surgery. This is an emergency. That's what they're saying because I guess it's in that law, MTALA law, whatever. The surgeon has to come because it's an emergency. He has to come and do the surgery. Now, if the surgeon still says no, I'm not coming, I guess the doctor has to try to contact another surgeon to come do the surgery immediately. Now the doctor contacts another surgeon and the surgeon comes and do the surgery, then the doctor can report the first surgeon that says I'm not doing the surgery can report him. But they have to first take care of the patient. So find another surgeon to do the surgery. I think that's what they're saying.
Okay.
Does it make sense?
Yes.
Mhm. Can you read A?
Administering hydromorphone of the hernia and obtaining CT scan of the abdomen are both inappropriate. This patient demonstrated clear clinical signs of hernia strangulation. Manual reduction will not be successful in this case. CT scan is unlikely to provide additional information. The next step in management is surgical exploration. Okay.
Okay. So first you tell the surgeon to come. If he doesn't come, you call the second surgeon. If they don't come, whatever. And once they do the surgery, then you report whatever to the violation MTALA thing. Okay. Next.
So who is violating MTELA?
The first one, because if he says
If
he don't want to come to do the surgery.
okay,
Yeah. The surgeon, I guess, because you need the surgeon to do the surgery. The on-call doctor, just normal PCP, cannot do the surgery. So he needs to call the on-call surgeon. The Yeah, the surgeon.
okay.
55 men comes to the office because of a 2-month history of moderate right shoulder pain. 2 months. The patient says that the pain occurs whenever he raises his right arm straight up in front of him or from his side. Okay. He also reports decreased strength in his right shoulder. He says he injured his right shoulder 35 years ago during a college football game when he was hit by another player and landed shoulder first on the ground. After the injury, he had pain in the shoulder that resolved in 3 days without treatment. He has not had any subsequent injuries to the shoulder. Medical history is fine. He takes no medication. Vital signs fine. Physical exam discloses inability to resist downward pressure on right arm when it's held straight out in front with the thumb pointing downward. This is some kind of sign. I forgot what it is.
Yes.
Which of the following imaging studies of the right shoulder is most likely to confirm the diagnosis?
Maybe it
Sometimes.
is empty can test. Empty can and full can test. You write the empty can, then you can find. Okay, if this patient has empty can, sign is positive. So maybe rotator cuff injury. Rotator
Mhm.
cuff. Rotator cuff tendinopathy as for if it is rotator cuff tear or then okay. The rotator cuff is a group of muscle and tendons. The rotator cuff is a group of muscle or tendons that act to sit the humeral head directly into the center of the glenoid during motion of the shoulder. These muscles also act in the concert. These muscles also act in the concert with each other muscles in the shoulder to internally and externally rotate, abduct, adduct the shoulder. These muscles include subscapularis, teres minor, supraspinatus, infraspinatus. The primary mover of this muscle and glenohumeral joint include internal rotation like subscapularis, external rotation like teres minor or infraspinatus, and abduction supraspinatus. The coupling and antagonistic action of this muscle, action, the coupling and antagonistic action of this muscle sits the humeral head in the glenoid and provides a stable pivot upon the trigger upon which the larger, the more powerful muscles of the shoulder can act, such as latissimus dorsi, pectoralis major. Rotator cuff tear usually Rotator cuff tear typically occurs at the insertion of the tendon of the rotator cuff on the humeral head. The humeral head commonly this occurs in the supraspinatus tendon. However, tears can occur in any of the rotator cuff tendon. Can be or at the myotendinous junction. Risk factor of the rotator cuff tear include heavy labor, rapid exertion of heavy labor, repeated head lifting, diabetes, malaria, vascular disease. Chronic disease can lead to tendon degeneration as well as acute or repetitive microtrauma are thought to be confused. The late manifestation of the tear include clinically appreciable atrophy of the corresponding muscle. MRI is typically indicated for patients with rotator cuff injury to delineate the extent of the injury, to determine the need for or to plan for surgical intervention. Okay,
Maybe BD.
yes. Arthrography is a diagnostic modality to evaluate the joint structure, function, and intracapsular pathologies. This patient's presentation is most consistent with extra-articular pathology. An ultrasonography of the shoulder is limited and can evaluate the joint effusion and acute soft acute soft tissue inflammation such as bursitis. MRI or CT imaging are more sensitive and specific shoulder pathologies. Okay. Can we take a break for 5 minutes?
Yes.
Okay.
Yes. Let me share. Okay, can you see my screen?
Yes. No. Yes.
Yes,
Now.
okay. 25 women brought to the emergency 45 minutes after onset of dizziness. Her symptoms began after she consumed like 1,800 milliliters of water during a contest in which participants tried to drink the most water in 15 minutes. She has no history of serious illness, no medication, and however, she's alert and fully oriented. Pulse is fine, regular respiration fine, BP yes, fine. Exam including neurological shows no abnormality, labs, sodium is super low, potassium is fine, urea is just low, glucose is fine, creatinine fine, urine specific gravity is low. Administration of which of the following is the most appropriate next step in management?
Okay. Like after taking this lot of fluid, this sodium can fall such low.
It
Is it
seems like,
possible?
yeah,
I can have 1 liter at a stretch, but 1800 ml. Okay, this question is a bit confusing. Okay. Excessive free water consumption over a rapid period can lead to acute hyponatremia, which, if severe, may include neurologic uh, manifestation, altered mental status, seizure, central nervous system, herniation syndrome, coma, and death. Acute consumption of free water results in dilution of renal interstitial concentration gradient, and limits concentration ability, resulting serum and urine abnormalities include hyponatremia, lower serum osmolarity, and low urine osmolarity, including hyponatremia, low serum osmolarity, and low urine osmolarity. Hyponatremia, if mild, does not Hyponatremia, if mild, does not generally cause symptoms or objective examination findings. Treatment of treatment of hyponatremia involves treatment of any underlying disease and gradual sodium correction, typically with fluid restriction in case of psychogenic polydipsia and syndrome of inappropriate antidiuretic hormone. A safe rate of sodium correction is generally no more than 6 to 12 milliequivalent per day. When hyponatremia is corrected too rapidly, extracellular sodium exerts osmotic pressure that leads to rapid efflux of sodium from neurons, which can lead to demyelination. The pons is particularly vulnerable to demyelinating injury, and the rapid correction of hyponatremia can result in central pontine myelinolysis. In cases of acute severe hyponatremia with neurologic symptoms of consequence, seizure, coma, and herniation, altered mental stress, correction with hypertonic saline is appropriate.
yeah.
Okay.
Makes sense now. Yes.
Uh, there is only clue is that one, but my problem is
Mm-hmm.
just consuming such high amount of fluid. The sodium can fall such high. That is my concern. Is it possible? Is it
They're saying that if it's in a short period of time, a lot of fluid in a short period of time,
because
so quick.
sodium is very low, not
Mm-hmm.
128 is okay.
Mm-hmm. Yeah.
Okay.
It's just because it's in a short period of time. Yeah, that's
Okay.
why they cause that. Okay. Okay. Next. Previously healthy 57-year-old man brought to the ED immediately after being involved in a head-on motor vehicle collision. He was the driver and was wearing a seatbelt with a shoulder strap. On arrival, he's alert and oriented. He says that he does not think he had loss of consciousness but feels sore all over his body. Temperature is fine, BP, pulse is 100, respiration fine, BP 140 over 70, pulse oximetry on oxygen via nasal cannula is 99. Physical exam and ECG shows no abnormality. Checks X-ray shown. Which of the following is the diagnosis?
Okay. Okay, it is aortic disruption. Traumatic disruption of the aorta can occur, or traumatic disruption of the aorta can occur in deceleration injuries such as motor vehicle collisions or falls. Patient can present with tearing chest pain, hypotension, hemodynamic instability, and tachycardia. Many patients with complete transection or rupture of the aorta do not survive to evolution, and many decompensate abruptly. The gold standard involves the CT angiography of the aorta. However, hypotensive patients may be too unstable to tolerate a CT scan, A chest CT can be obtained which may show a widened mediastinum as seen in this patient. CT angiography of the chest can differentiate types of the blunt aortic injury, including aortic dissection, aortic rupture, pseudoaneurysm. Repair of traumatic dissection of the aorta can be performed via open repair. Such patients are often critically ill. Such patients are often critically ill and hemodynamically unstable, and attention must be paid to hemodynamically support and reversal of coagulopathy if present, and surgical evaluation without delay for advanced imaging in cases of high pretest probability.
Can you read C, D, and F?
Yes, perforation of the esophagus can occur. Perforation of the esophagus can occur multiple causes including forceful vomiting, Boerhaave syndrome, trauma, invasive malignancy, inflammation. Translocation of the gastric content into the mediastinum can cause rapidly progressive infection and sepsis from mediastinitis. Esophageal perforation is a surgical emergency and is diagnosed through water-soluble contrast esophagography. Perforation of intra-abdominal viscous Perforation of the intra-abdominal viscous may lead to severe diffuse abdominal pain, nausea, vomiting, high fever, tachycardia, septic shock. Bowel contents in the peritoneal space cause rapid infection in the form of peritonitis, marked by abdominal rigidity, rebound tenderness, and guarding. Perforated viscous and resultant peritonitis is a surgical emergency that requires exploratory laparotomy. Pericardial effusion presents with hypotension, shortness of breath, distant heart sound, jugular distension, and pulsus paradoxus. If tamponade is present, muffled heart sounds may be the only clue. If tamponade physiology is absent, rapid decompression of the pericardial space is required to prevent ongoing shock. X-ray imaging is generally normal in acute tamponade.
Okay. Next. 77 men comes to physician because 2 week history of increasing back pain. 2 week. 8 years ago, he was diagnosed with prostate cancer. Gonadotropin inhibitor therapy was began, and he was asymptomatic until 2 months ago. Metastatic lesion at L3, T4 were confirmed at that time. Uh, Ibuprofen therapy sufficiently controlled the pain for 1 month, after which oxycodone 5 milligrams every 4 hours and laxatives were added to the medication regimen. His last visit 1 month ago, he reported his pain was between 0 to 2 on a 10-point scale. He now describes the pain 4 to 5 on a 10-point scale. Which of the following is the most appropriate next step in management?
Okay. Opioid are potent analgesic that reduce the sensation via delta kappa, particularly mu opioid receptor agonism, throughout the central and the peripheral nervous system. Despite their high potential lead to opioid use disorder and the overdose death, opioid agonists are useful for the management of pain in certain situations, such as in the perioperative period following trauma and in the setting of cancer, which can produce severe chronic pain that is often intractable to their modalities. Treatment with opioids typically employ mu-opioid receptor agonists such as morphine, oxycodone, hydromorphone, fentanyl, or methadone. Dose titration is often necessary after beginning initial therapy. Oral opioids are typically administered on a fixed, scheduled dose. Breakthrough or progressive pain can be treated by breakthrough or progressive pain can be treated by increasing the scheduled dose, usually by at least 25%. The percentage increase in dosage is informed by the severity of pain and assessment of other comorbidities and risk factors for overdose. Patients with uncontrolled pain or on high oral doses of opioid may benefit from transdermal patches or intravenous administration.
Okay. Okay, so for opioid, you first try to increase the dose, and then if that don't work, you do give the transdermal patch or the IV. Okay.
Yes.
Okay.
No, when morphine is used, like transdermal patch or IV morphine,
What do you? I don't understand.
begin the option C.
Uh-huh.
Okay, begin intravenous morphine therapy is appropriate strategy for intractable pain, but this is premature at this point. Okay.
Next. 18 woman comes to physician for follow-up exam. Um, yeah, so you need to add it because there was one question. I don't know if it was yesterday. So you need to make sure if you increase from to 25%. There was one question that we saw. I don't know if it was
Yes, it was
yesterday.
given 4 hourly. Yes,
Yeah,
that
and
was the
then
maximum.
yeah, and then they were asking what is the next step, but the next step was to add the transdermal patch. It
Yes,
wasn't to increase the dosage. There was one option that said increase the dosage. The other one was to do the transdermal, but the right answer was the transdermal patch
maybe
because
that was the highest limit
yeah, it was
for
the
that
highest
drug.
one. Yeah,
That was the highest limit. For
yeah,
oxycodone, maybe it is not the highest limit. It has
mm,
some upper dose.
yeah, probably. 18 woman comes to physician for follow-up exam. She has a 5-year history of asthma treated with inhaled albuterol as needed and inhale steroid daily. She has never required treatment in the hospital for acute episode. She says that her asthma is worse after she spent prolonged periods of time indoors and after she visits home of friends who have cats. Her house has hardwood floors which she and her family clean every week. She sleeps with her windows closed and changes her bedding regularly. She doesn't smoke or drink alcohol. Examination shows no abnormalities. The lungs are clear. Skin test shows allergies to dust mites and cat dander. Physician advises patient to avoid contact with cats. Which of the following environmental changes is likely to be most helpful in preventing exacerbation of this patient asthma?
Okay. Preventive management of asthma. Preventive management of asthma involves controlled therapy and avoidance of known triggers. Asthma triggers can be divided into allergenic or non-allergenic categories. Non-allergenic triggers such as cold exposure and exercise can be anticipated. Allergenic trigger can be more difficult to control, especially in indoor environment. The most common indoor allergen are dust mite, pets, and molds. This patient has noticed this patient has noticed an association between her asthma symptom and being indoor around cats. Skin testing confirms her hypersensitivity to dust mites and cat dander. One of the most effective proven strategies for minimizing dust mite exposure is the use of allergen permeable mattress and pillow covers. These
Okay.
have long shown to reduce the asthma symptoms in sensitive adults. Okay.
Okay. Next. 44 men comes to the office because 6 month history of intermittent moderate headache. He has had 1 to 2 headaches weekly since residents of the neighboring apartment got a dog that barks a lot. Okay. He says he has had recurrent thoughts of what killing the dog during the past 6 months, but he has had no intent or plan to harm the animal. He worries that his headaches are punishment for these thoughts about killing the dog. He says he realizes this does not make sense but remains concerned. He vacuums 2 hours daily because he is worried that dog air is coming into his apartment. He has no history of serious illness. His only medication is acetaminophen, which resolves his headaches. He drinks 2 to 3 beers on the weekend, which his pulse is fine, respiration fine, BP is high. Physical exam shows no other abnormalities. Mental status exam shows anxious affect. What is the diagnosis?
What is your diagnosis?
It's OCD. Yeah.
Okay. You want me to read the explanation?
Oh, yeah, yeah.
Okay. Obsessive compulsive disorder is an anxiety disorder typically characterized by obsession, unwanted, intrusive thought that produce anxiety that the patient attempts to neutralize with compulsion, repetitive behaviors. By definition, the compulsion are excessive or do not realize realistically address the obsessive fear and patients commonly recognize the irrationality of their symptoms. These patients' thoughts of killing his neighbor's dog as well as worry about dog hair entering his apartment represent obsession while his excessive vacuuming represents a compulsion. Treatment includes use of SSRI, have the lowest adverse effect burden of antidepressant medication. Clomipramine and venlafaxine, SNRI reuptake inhibitor, are effective second-line agents. Okay.
Okay. Yeah. Next, 27 primigravida woman, 32 week gestation comes to the ED because 2-day history of progressive drooping of the right side of her face, an inability to close her right eye, and right-sided facial pain. She has not had loss of hearing or balance. Her pregnancy has been uncomplicated. She has no personal or family history of serious illness. Temperature is fine, pulse is fine, respiration fine. BP, a bit high. Exam of the face shows paralysis of the right side and inability to close the right eye. The patient moves her head stiffly. There is no knuckle rigidity. Her sounds normal. There is a 2 out of 6 holosystolic murmur. Heard best at the apex. The abdomen is soft. Fundal height is 32, so fine. There is mild edema of the lower extremities. Muscle strength is normal. Deep tendon reflex normal. Which of the following is the most appropriate next step?
What is your diagnosis?
Some kind of
Bell's
cranial
palsy.
Bell's palsy. Yeah.
Okay.
Yes. Yeah.
So complete paralysis of one side. In Bell's palsy, there is lower motor neuron type of paralysis. In lower motor neuron type of paralysis, everything involves. In upper motor neuron, upper part of the face is spared. That we need to remember. Okay.
Mm-hmm.
Complete paralysis of one side of the face with no other neurologic lesion is consistent with an ipsilateral lower motor neuron lesion of the facial nerve, cranial nerve 7, as in Bell's palsy. Bell's palsy, also known as cranial nerve 7 palsy, may be result of viral infection or inflammation of the nerve. It presents with unilateral weakness of the facial muscle. It presents with unilateral weakness of the facial muscle, including those of the forehead. It is differentiated from the ischemic stroke, which typically demonstrate intake forehead musculature, as these muscles are dually innervated by the upper motor neuron from the bilateral precentral gyri, bilateral upper motor neuron from bilateral precentral gyri lesion involving the lower motor neuron, facial expression, facial nerve inflammation. In Bell's palsy affect the forehead and the lower face together. Bell's palsy incidence or severity are increased in pregnancy and increased in increased in pregnancy, and cases typically arise in the third trimester. Cases typically arise in the third trimester of postpartum period. Treatment of Bell's palsy involve corticosteroid therapy, occasionally antiviral depending on the severity. Supportive care measures such as eye patches and artificial tears are appropriate to limit ocular complications. Okay.
Okay. So, how do you know that here that the right forehead is involved from the?
Okay. Look at the question stem again.
Mm-hmm.
Okay. She has two, sorry, okay, 32 weeks, 2-day history of progressive drooping of the right side of the face. So, drooping of the right side of the face, inability to close her right eye. So, eye involvement, and there is drooping. So, that means that upper part has not spared. If you look at the eye
Mm-hmm.
and you tell, like what how we do the test, we tell the patient to close the eye as hard as he can, and then we try to open the eye. If we can open it easily, like you try to close your eye, and if I try to open your eye, I will not gonna successful, because you can close your eye with your full
Mm-hmm.
force, isn't it?
Mm-hmm.
But
Mm-hmm.
this type of patient, if you tell him to close his eye, and if you see that he is unable to close his eye. There is,
Mm-hmm.
you can see the inner part of the eye. So it is easy to diagnose that he has Bell's palsy, not stroke.
Mm-hmm. Okay.
So the forehead, and in forehead, like we tell the patient to look upward, and if you look upward, there is a wrinkling. But in Bell's palsy, there is absence of wrinkling on the particular side. So this too is a classic feature for the Bell's palsy, like the uh, absence of wrinkling and closing of the eye.
Okay, so they cannot close the eye completely. So that
Yes,
means
they
the
yes
forehead
they
is
cannot close the eye completely. And other findings are not important. I need to see these two things.
okay. That means the forehead is involved.
Yes,
Oh,
that means
okay.
the forehead is involved. So as forehead is involved, it is lower motor.
Okay. Okay. Next. 73 woman brought to the clinic by her husband because of a 6-month history of progressive memory difficulty. Okay, during this time, she has misplaced objects more frequently than usual and has had trouble following recipes. 6 days ago, she became lost while walking the dog in the neighborhood. Today, she forgot that the daughter had called the previous day. The patient has type 2 diabetes, hypertension, medication, metformin, lisinopril, no cigarette smoking, no alcohol, vital signs normal, physical exam normal, mental status exam. She's oriented to person but no place or time. She recalls 0 out of 3 objects after 5 minutes. She makes 4 errors performing serious. 7. She can name the US president and vice president. She can name 8 animals in 1 minute. Reminder of the exam is fine. Results of CBC, ESR, and liver and thyroid function tests are normal. VDRL for syphilis negative. MRI of the brain is shown. Which of the following is the most appropriate next step in management?
So what is your diagnosis?
I, I don't know. From the city, I don't know. I guess she has Alzheimer's. I
Yeah.
wouldn't know that from the city.
Okay. Okay. These are so in Alzheimer, what are the drugs we use? Dr. GM, donepezil, rivastigmine, galantamine, and memantine. The
I feel
donepezil, sorry,
like you gave me that thing before. You
yes.
said, yeah, I feel like you gave me that.
The first three, donepezil, rivastigmine, and galantamine, may be a cholinesterase inhibitor, like anticholinesterase, and memantine may be NMD receptor antagonist. Oh, okay. Okay, I'm reading the explanation now. Oh,
Okay.
this patient presenting with classic signs and symptoms of dementia. Dementia, Alzheimer type is most prevalent dementia, presenting with progressive cognitive decline that begins with a short-term memory impairment, progress to apraxia, language abnormality, culminates in behavioral and personality changes, preventing the patient from performing basic activities of the daily living. Dementia Alzheimer type is postulated to the result from decreased cholinergic signaling in the cortex and the basal forebrain. Anticholinesterase normally hydrolyze the acetylcholine in the synaptic cleft. Treatment with cholinesterase inhibitor such as donepezil non-competitively and reversibly inhibits anticholinesterase activity and thereby increases the amount of synaptic acetylcholine available for neurotransmission. Though these agents may slow the rate of cognitive decline, modestly improve functionally, they are not curative. Okay.
Mm-hmm. Okay. So were you able to diagnose it from the CT, from the scanner, from the MRI? Sorry, the MRI.
uh, no. I
Okay.
I can diagnose only the NPH.
Okay. The MPH will look like what?
NPH will there is a ventriculomegaly.
Ventriculomegaly. Okay. Next, previously healthy 77 men comes to the ED because of 6 hour history of increasingly severe 6 hour history of increasingly severe non-radiating lower abdominal pain. He also has had urinary urgency during this time, but has not been able to void for 8 hours. Hmm. He has not had fever, chills, diarrhea, or vomiting. Vital signs are normal. Exam, there is fullness in the midline. From the umbilicus to the pelvic symphysis, the area is tended to palpation, but there are no peritoneal signs. Rectal exam shows an enlarged prostate. Sphincter tone is normal and no masses are palpable. Which of the following is the most likely diagnosis? Hmm.
Okay, this is BPH. So benign prostatic hyperplasia affects middle-aged and elderly male patients, and middle-aged and elderly male patient it occurs as a result of excess growth of tissue in the central zone of the prostate causing lower urinary tract obstruction. BPH presents with urinary dribbling and incontinence, difficulty starting and maintaining urinary stream, nocturia, and the need of frequently urinate and incomplete voiding. These symptoms are typically insidious in onset, chronic and progressive urethral and bladder outlet obstruction may lead to acute symptoms, pelvic pain, along with inability to void, and may predispose to cystitis, hydronephrosis, pyelonephritis. The diagnosis of the BPH by history, physical examination, and urodynamics testing, along with ruling out of alternate diagnosis. Prostatic malignancy treatment includes supportive care, alpha blocker, tamsulosin, 5-alpha reductase inhibitor, finasteride surgery. Acute obstruction can be managed with catheterization in order to decompress the urinary bladder and present with the complication of prolonged bladder outlet obstruction, such as bladder rupture, urothelial cell atrophy or necrosis, hydroureter hydronephrosis, post-renal azotemia, and end-stage kidney disease. Okay,
Okay. Can you read the F?
okay. Urinary tract infection may occur in the setting of BPH and bladder outlet obstruction. These patients' acute symptoms, inability to void, and pelvic pain are more sensitive or bladder outlet obstruction secondary to BPH. Then a urinary tract infection typically presents with dysuria. Okay, when we will think about BPH, what are the features like rectal examination showing enlarged prostate?
Mm-hmm.
One feature. No masses are palpable. Okay, no like not prostatic adenocarcinoma, and
Mm-hmm.
the like the features of frequency urgency nocturia. This
Mm-hmm.
okay, and there may be hesitancy. Other there are lots of symptoms regarding BPH.
Yep. Yep.
So this rectal examination is important, like enlarged prostate.
Mm-hmm.
Okay.
Next. 6-year-old brought to the ED by his parent because 2 hour history of severe right leg pain and refusal to walk. They say 2 hour history. They say he has intermittently reported pain in his leg during the past 2 weeks. He has no history of trauma or serious illness, no medication, growth and development are fine. Temperature is high, pulse is high, BP low. There is BP, I guess, yeah, normal. There is warmth and tenderness to palpation of the proximal aspect of the right tibia with an associated firm mass. Distal pulses are intact. Range of motion of the right knee is limited by pain. Muscle strength in the right lower extremity is 4 out of 5 because of pain, and 5 elsewhere else. Sense, yeah. Sensation is intact. Lab study shows hemoglobin concentration, I guess, is low. Leukocyte count is high. ESR is, I don't know. I guess that's normal. Not sure. X-ray shows a 6 centimeter poorly defined lytic lesion in the proximal tibia, metadiaphysis with adjacent periosteal reaction. The results of the biopsy have shown, Jesus, which of the following is the most likely diagnosis?
Why it is Ewing's? What are the feature you have found?
No, I didn't find. I got the wrong answer.
Sorry?
I got the I
Okay.
answered wrong.
So Ewing's happen in the diaphysis. One clue. Preferentially, yes. Ewing's happen in the diaphysis. Um, if we rule out other, then we can find out. But lots of things we do not know.
Mhm.
Ewing sarcoma is a primary bone malignancy typically present in the childhood. Typically present in the childhood, adolescent, early adulthood, occurs frequently in the long bone, or occurs frequently in the long bone. Frequently occurs in the long bone and the extremity as the femur or the tibia or in the axial skeleton as the femur or tibia or is in the axial skeleton such as in the pelvis. Patient typically present with insidious onset. Patient present with insidious onset, dull pain suddenly exacerbated by exercise or minor trauma. The neoplasm is derived from bone mesenchymal precursor and driven by 11-12 chromosomal translocation. 11-12 chromosomal translocation, which results in the formation of ongoing fusion protein extrematio elevated periosteum and layered neocortex formation. The diagnosis is confirmed by biopsy, which shows multiple small round blue cell, multiple small round blue cell. The prognosis often poor for patients which are older at initial presentation and with axial skeleton involvement or distant metastasis. Treatment is local surgical excision, radiation therapy, systemic, usually a combination of regimen. Okay, in the Ewing sarcoma, in X-ray there is a central lytic lesion with a moth-eaten appearance. This word is present, but it is not present in here. This is classic, like moth-eaten appearance with central lytic lesion, and
Mhm.
there may be lamellated periosteal reaction like onion skin. And biopsy is confirmatory, like they have said, like biopsy shows small round blue cell. Okay, so we need
Okay.
to find out with the histology. There is no other clue. Okay, you want to end here?
Um, no, we can go like 5 more minutes. But
Okay,
then yeah, the clues because it says lytic lesion here on the thing, and it
yes.
also says periosteal reaction. And I think Ewing sarcoma has the small blue round cells too. So they
Yes,
gave a lot. They gave a lot of clues. They did. Okay. Next. 39
you are
woman.
seeing small blue round cell on the histology
Oh,
picture.
yeah, these ones. Oh, do they don't look like small blue?
Yes, they
No,
do.
they do. I mean, I don't know. They do, right?
Yes, they do.
Yeah. Okay. I mean, I hope so. I mean, I think.
No, no,
Uh,
no, you were right, but
okay.
it is it usually uh as we are in a deep, as we have given the deep look, that's why we are saying that there is small blue cell, but
Yeah,
casually this is very hard.
it's hard to. Okay. 39 men comes to office because 1 month history of intermittent regurgitation and constipation. He has regurgitated. This is bad. He has regurgitated and digested food 4 times weekly. He previously had daily bowel movement during the past month. He has had bowel movement every 3 to 4 days. He also has a 1 year history of progressive difficulty swallowing. He says initially he had difficulty swallowing solids. He now has difficulty with liquids. When he eats, he occasionally has moderate pain in the lower sternal area that radiates upward. He immigrated from Brazil 5 years ago. Vital signs normal. Exam shows no abnormality. Checks X-ray shows dilated esophagus with air fluid level. Which of the following is the most likely diagnosis? Oh, that's why.
Okay, lots of thing is given like megaesophagus and uh, uh, came from Brazil. The picture in the sketchy, the boy and the girl who kissed in the like in the field.
Mm-hmm.
So that one is the like Chagas disease.
Mm-hmm.
This one,
Yes, this
like
one.
megaesophagus,
Mega
megacolon,
and mega
and
heart.
yes, megaheart. And like in the treatment,
Oh, treatment,
suramin,
sorry.
sorry,
Uh,
suramin or nifartimox. Sorry, nifartimox, and another is uh,
benzimidazole. I
there is
never heard.
another drug,
Oh, there's another one.
nifartimox. Okay, okay, nifartimox.
Yeah.
Okay, megacolon, megaesophagus. Okay. So South American trypanosomiasis or Chagas disease results from infection with parasitic infection with parasitic flagellated protozoan Trypanosoma cruzi. Trypanosoma cruzi is acquired through the bites of the red uvid insect and species widely found throughout the South America, Central America, and areas of the southern United States. Red uvid insect are nocturnal and fed on sleeping human hosts. They are common in the rural areas and infest thatched roof, crack or holes in the poorly built housing. South American trypanosomiasis manifests with an early acute stage characterized by mild non-specific symptoms of fever, malaise, and lymphadenopathy and splenomegaly, which can last for 1 to 2 months and resolve spontaneously. They may be There may be mild swelling and erythema at the site of the bite and commonly on the eyelid or near the mouth. South American trypanosomiasis is usually curable if treatment is initiated promptly during the acute stage. If not detected or treated, During the acute stage, a chronic infection typically ensures, which is not curable. Chronic South American trypanosomiasis is characterized by cardiac manifestation, including dilated cardiomyopathy, arrhythmia, congestive heart failure, along with GI manifestations such as constipation, esophagus, which can produce dysphagia, odynophagia, weight loss. The diagnosis confirmed with a variety of the tests depending on the chronicity of the infection and may include peripheral blood smear to detect extracellular parasite polymerase chain reaction, an enzyme immunosorbent assay, and treatment involves prolonged courses of antiparasitic drugs such as nifurtimox and benzimidazole. Treatment of chronic phases supportive oriented toward the management of the cardiac and the GI complications. Okay.
Okay. Next. Hospitalized 27-year-old woman with sickle cell disease, sickle cell crisis, has shortness of breath and non-productive cough 4 hours after transfusion. Okay. Of 1 unit of packed red blood cells. So only medication is morphine, temperature high, pulse high, respiration high, BP low. Pulse oximetry on room 8, oxygen saturation 88. Um, examinations on central cyanosis. Diffuse crackles are heard bilaterally. Heart sounds normal. Arterial blood gas pH is normal. Nope, it's high. PCO2 is normal and PO2 is low. Checks X-ray shows bilateral pulmonary infiltrates. Which of the following is the cause of these findings?
So after giving blood, there is fever, hypo, hypotension, tachycardia, and there is diffuse crackles. Oh, so it is transfusion-related acute lung injury. TRALI.
Mhm.
Transfusion-related acute lung injury is a rare complication of blood product transfusion, but a common a common cause of death related to transfusion. It commonly presents during within 6 hours after transfusion, with symptoms including fever, cyanosis, hypertension, hypoxemia. Physical examination may disclose crackle or auscultation of the lung. Chest X-ray will show new bilateral pulmonary infiltrate unrelated to cardiac dysfunction. The pathology thought to be caused by the activation of the neutrophil in the pulmonary vasculature by antibodies in the transfused product, which can lead to release of cytokines and inflammatory mediators. Risk factors of this development include patients' risk factors such as tobacco use, fluid overload, shock, alcohol use disorder, mm, alcohol use disorder, plasma proteins, plasma platelet plasma, and whole blood carry the greatest risk of TRALI. Treatment include discontinuation of the transfusion and oxygen supplementation in the form of non-invasive positive pressure ventilation or intubation and hemodynamic support. Okay,
Can you read all the other answer choices?
yes. AV incompatibility occurs when a patient receives inappropriate type and crossed transfusion product. This leads to acute hemolysis as the patient's antibody attack the transfused red blood cell. It presents with fever, rigors, flank pain, hematuria, hypotension. It does not cause hypoxemia or bilateral pulmonary infiltrate as in this patient. Anaphylactic transfusion reaction is a rare IgE-mediated transfusion reaction, most often seen in patients with IgA deficiency or or in patients who are allergic to substance used to store blood product. Symptoms include bronchospasm with associated dyspnea or wheezing, urticaria, flushing, nausea, emesis, edematous lips and tongues, hypotension, tachycardia. This patient has primarily respiratory symptoms including hypoxia, bilateral pulmonary infiltrate, making trali a more likely cause of the symptoms. Fluid overload often present with peripheral and pulmonary edema, often after large volume resuscitation. Pulmonary edema can cause dyspnea, hypoxemia, and bilateral pulmonary infiltrate on X-ray as seen in this patient. However, it is less likely to cause fever and hypertension and would be unlikely to occur after only single blood product transfusion. Hemolytic transfusion reaction commonly occurs as a result of API incompatibility. It presents with fever, rigors, flank pain, hematuria, hypertension. Lab evaluation may disclose acute kidney injury or signs and symptoms of DIC. It less likely than TRALI. Okay.
Okay. Yeah. Last question. 22 men comes to physician because of severe nosebleed and generalized rash for the past 24 hours. Nosebleed and rash. He has 1 month history of fatigue and generalized weakness. His temperature is fine. Pulse is, I guess, a bit high. Respiration fine. BP 142 over 72. Exam of the skin shows diffuse petechiae over the entire body. Okay. There is diffuse lymphadenopathy and mild hepatosplenomegaly. The nerves are packed with gauze, and there is no active bleeding. Labs hematocrit. Hematocrit is, I believe that's low. Leukocyte count is high. Hmm, let me go there first. Hematocrit is low. Leukocyte count is high. Segmented neutrophil is low. Lymphocyte is normal.
And platelet count
Lymphoblast,
is very low.
yeah, platelet count is there. Lymphoblast and other immature form is there. Urine, creatinine and urea are high, and uric acid. Wait, is it high? I think it's high.
Yes,
Biopsy specimen, yeah. Biopsy specimen of bone marrow shows ALF. In addition to vigorous hydration and alkalization of the urine, which of the following is the most appropriate to administer to prevent acute renal failure during
okay. What is your
chemo?
diagnosis?
Like, mm,
Tumor
what the
lysis?
okay, if when they're gonna start the chemo, yeah, tumor
Yes.
lysis. They wanna prevent tumor lysis, yeah. Mm,
Tumor lysis syndrome occurs following the initiation of the chemotherapy for leukemia or lymphoma. The abrupt destruction of large number of tumor cells results in interstitial and serum release of intercellular contents manifesting as hyperphosphatemia, hypocalcemia, hyperkalemia, hyperphosphatemia, hypocalcemia, hyperuricemia. Patients with tumor lysis syndrome can present with fever, nausea, vomiting, diarrhea, lethargy, cardiac dysarrhythmia, seizures, tetany, muscle cramps. Syncope are at risk for sudden cardiac death secondary to associated with electrolyte and metabolic abnormalities. Purine, nucleic acids are metabolized to hypoxanthine and xanthine, uric acid, which are converted to uric acid by xanthine oxidase, resulting in hyperuricemia. Uric acid can crystallize in the renal tubule, leading to nephropathy and acute kidney injury, or it can deposit into the joints, leading to arthalgia or gout. Patients undergoing induction chemotherapy should be monitored for tumor lysis syndrome and treated prophylactically. with aggressive intravenous hydration along with allopurinol and antioxidant inhibitor or reduced uric acid and a recombinant uric acid oxidase. Treatment of hemolysis syndrome involves supportive care and correction electrolytes and metabolic abnormalities. As uric acid is helpful in the treatment of TLS in patients with severe kidney injury or refractory electrolyte derangement. Renal replacement therapy with dialysis may be needed. Okay.
Okay, we are done. I will see you tomorrow.